Okay, and we're on. All right. I'm at the cost of sounding pretentious. I'm going to make a sweeping generalization about you guys today. I'm going to make the assumption that nobody read anything and probably didn't get a whole lot out of the lecture last week.
Last week we did.
Probably didn't. So yeah, I kind of gathered that. I think there was some stress level over midterms. So
We're like,
yeah, it was like it was like a bunch of zombies. So tell you what I'm going to do is I'm going to do a real quick recap of last week. We'll probably spend 15 or 20 minutes, do a quick recap, give you guys a Reader's Digest version of that, just so if you guys were really stressed out and you didn't read and you didn't really get a whole lot out of the presentation, which I imagine most of you didn't last week, at least we can hit the major points and you guys aren't totally, completely confused. So I just have a little worksheet here I made up. Let's start here. And what we'll do is we'll go through this. Here we go. One more. All right, so what I want to do is I want to try to distill all this stuff down and kind of put it into a nice little package for you guys, just to make it a little easier to. So the original one that I drew for you guys had all kinds of cool little colors on it, but I can't copy in color, so I apologize for that, but we can still go through it. Okay, so what I have, and I'll kind of try to replicate what you guys have. Okay, so we have this, and it should say mast cell in there. Okay, so we have the mast cell. And we know that mast cells can be sensitized, and they can degranulate in response to lots of different stimuli. Generally, this is going to be in response to some sort of antibody. And we'll talk about the major antibodies. We'll just touch them real quick. So let's just say that the mast cell, for whatever reason, lots of different triggers can cause this to occur, but the mast cell degranulates. Can everybody see over here? You guys in the corner? Okay. And that's actually what I drew underneath that, is a mast cell degranulating, and it's releasing pro-inflammatory substances. Everybody's okay there? Mm-hmm. And the big one that we are concerned about is histamine. Now, we have lots and lots of other types of pro-inflammatory substances, tumor necrosis factor, and so on and so forth that can be released, but this is a major one. And when this occurs, this causes a response, right? And this is what we call the early phase response, and I believe I drew that in for you guys there. So when we have this, we have the early phase response. And this is the asthma attack that we see in our patients. Some sort of trigger causes them to have issues, problems. Maybe it's an allergen, pollen, dander. Maybe they get a cold. Maybe it's cold air. What have you? This occurs, and they have the initial response. Everybody's okay there? They have that initial response. But is that all? Is that all they wrote, or does something else happen? Okay, yes. So these cells have degranulated, right? They basically ruptured, they burst, and they sent out the histamine. But what about the cell wall that's left behind? Okay, so that cell wall that's left behind after these cells break, that's basically the phospholipid layer. That's basically what a cell wall is. It's a phospholipid layer, phospholipid membrane. And the phospholipid membranes of mast cells have a substance within them. And that there's a little line there on the right-hand side of your paper. Do you guys remember what the name of that substance is? Arachidonic acid. Cool. All right. So what I'll do is arachidonic acid. Okay, everybody's good there? We have arachidonic acid. And arachidonic acid goes through a couple different pathways, right? And what are the two pathways that arachidonic acid can go through? And I kind of drew it like this. What's that? Okay, the cyclooxygenase pathway. And what is the other pathway that we can go through? The lipo. All right, good, good. This late phase, how long does this take approximately to occur? 6 to 8 hours. All right, good. All right. Everybody's following me okay? All right. The cyclooxygenase pathway, what substance is produced from this pathway? What class of substances? Cyclooxygenase are prostaglandins. Okay, prostaglandins. Okay. And what about the lipooxygenase pathway? What class of substances is produced through this pathway? Leukotrienes. Okay. Everybody's following me okay so far? All right. What effects can we expect from prostaglandins? What major effects will happen with the production of prostaglandins? Okay, we can have some clotting, right? Some clot prevention. What about the respiratory effects? What do we primarily get with prostaglandins? Okay, so we get constriction. And what else? So we get constriction and mucus production. Good. Increased mucus production. Okay, what about leukotrienes? What happens with leukotrienes primarily?
They inhibit?
No, they cause something to happen in our airways. So the prostaglandins we know cause constriction and mucus production. Leukotrienes will primarily cause, what's that? You guys, anybody remember? Inflammation. Airway inflammation is what happens here primarily. Airway inflammation. Okay. So what I've drawn here is the basic pathophysiology of this asthma response. Everybody's okay with that. We have the early phase, this happens right away. And then 6 to 8 hours later, we go into what's known as all of this stuff here, our late phase. And that was the first part of the class, the lecture last week. And it seems like you guys have a pretty good handle on that for the most part. I know sometimes it's real easy to get the cyclooxygenase and the lipooxygenase pathways kind of mixed up. So try to keep those straight. So is everybody okay on the basic pathophysiology? Okay. So let's talk about treating now, the treatments. And there are a few different little arrows. And I have an arrow here pointing to this here, the early phase response. What types of medications do we use to treat early phase response? What's the major class that we use to treat early phase? Right, and what does that fall into? What class? Bronchodilators, yeah, good. So this is where our bronchodilators come in handy here. Are generally our shorter acting ones, like albuterol. Our long acting ones aren't really good rescue drugs, but bronchodilators, and somebody had mentioned albuterol. Absolutely. Xopenex or levalbuterol are both types of bronchodilators that we use during the early phase response. Everybody's okay there? Okay. What is the duration of action on these bronchodilators? About 4 to 6 hours. Okay, and then 1 to 3 hours would be your catecholamine type bronchodilators like epinephrine and that, which we don't really use a whole lot because of all their adverse side effects and the fact they don't last very long. Okay, so we give our albuterol to our patient, and they get better. They're feeling fine, they're doing okay. Are we in the clear? No, because what do we potentially have to worry about? 6 to 8 hours later when we transition into the late phase. So now we have some other things to worry about. We've taken care of the emergency, we've rescued him. Now we have to worry about the late phase here. And are there medications that we can give to prevent or treat late phase response? Okay. So the major one that we run into, the big one that we can run into, and there's a little arrow, that arrow should go to leukotrienes. I think I put prostaglandin, I think I had the arrow going here, so you can just put a line through that and draw a little arrow to the leukotrienes here. And are there a class of medications that inhibit the production of leukotrienes? And what is that class called? Not COX inhibitors? Work over here, right? This is COX, cyclooxygenase. Steroids are special. We'll talk about those here in a little bit. Singulair, somebody mentioned Singulair is a medication from this class. What is the class called, though? Yeah, you guys are going to smack yourself in the head. Yeah, it's a leukotriene inhibitor. That's all. Yeah, so leukotriene inhibitor. Yeah, you guys are overthinking that just a bit much. And what is the major one that we talked about the other day? Somebody had already mentioned it. Singulair. Okay, so Singulair is a trade or generic name? Okay, the trade. What's a generic name for Singulair? Montelukast. There we go. Montelukast. Okay. So we can give a leukotriene inhibitor to work here. Everybody's okay there? Okay. Will leukotriene inhibitors treat an active episode, an active attack? No, they're preventative, right? They are what we call maintenance medications. Maintenance or preventative. So they're not rescue medications. But they can help prevent the late phase response from occurring. Okay. Is there another class of medications that we talked about last week that works as a maintenance medication, but it works somewhere else? What do you guys think? It doesn't work here, it works somewhere else. In the beginning. Here?
Yeah, you can stop that.
What is the name of that class of medications? You guys are going to hit yourselves again. You're going to hit yourself on the head when you figure out the name of this. It works. It relates to mast cells, right? Mast cell, not inhibitors, stabilizers. Oh, you guys remember? Mast cell stabilizers. Okay. So they prevent the mast cell from degranulating. And what is one of the major ones that we talked about last week? It starts with a C. Cromolyn. There we go. Cromolyn. Cromolyn, which is generic. What's the brand name, or one of the brand names that we run into? It starts with an I. Just have Intel or Intal? Yeah. Okay. Is this a rescue medication? No, these are not, right? These are maintenance as well. Okay, good. All right. And then we talked about one more class of medications. Do you guys happen to remember? What's that? The steroids. And the steroids are kind of special because they work kind of all over the place. They work multiple different areas. So what I did is I just kind of drew a little thing on the side of the paper that kind of looks like this, and then I put steroids. Okay, they inhibit a lot of different things. And what was one of the major steroids that we talked about last week? Pulmicort. Good. Then that's a generic or brand name? Okay, brand name. Pulmicort. And what is a generic name for budesonide? There we go. All right. Good. And let's just go ahead and cover the doses of these major medications. The nebulized adult dose of budesonide or Pulmicort, what's the common dose that we talked about?
0.5 milligrams.
Okay, 0.5 milligrams. Everyone's good there? So, what about singular for an adult?
10 milligrams.
10 milligrams, good. 10 milligrams. And how do we give singular? Is it nebulized? Is it injected? Dry powder inhaler? How do we give? Primarily, how do we give singular? It's a tablet. There you go. It's an oral. We give it PO. For the most part, yeah, it's an oral medication. Okay. And are you guys good on bronchodilators? What's your standard dose for albuterol? 2.5 to 5 milligrams. Good. Can we repeat that if we need to?
Yes.
Yes. Can we mix 5, 10, 15, 20 milligrams on a large volume nebulizer and give it continuously if we had to? Yes, absolutely. So there are several different ways we can give albuterol. What about Xopenex? What's the standard dosing for adult dosing for Xopenex? 0.63 to 1.25 milligrams. All right. Guys, that is, in a nutshell, what we talked about last week. Steroids, are steroids rescue medications? No, they're not, right? They're not rescue medications. So let's talk about when we give these medications real quick. If somebody comes into the ER, or you get called to the floor and they're having bronchospasm, and we suspect this type of pathophysiology occurring, what do we give them first? Okay, we rescue them, right? Mm-hmm. Then what do we need to look at doing?
To prevent the late phase.
Okay.
Cortisol.
So maybe looking at a steroid?
Yes.
Okay, good, good. And so we'll give this, and then we'll consider a steroid, adding a steroid in, and then let's say that they're getting ready to go home, and we need to look at maintenance therapy. Then what can we consider? Maybe going with a leukotriene inhibitor, mast cell stabilizer, something like that. Would you guys agree? Mm-hmm. So do you kind of understand where all these fall into the treatment of a patient? Mm-hmm. So if you get a scenario, a patient comes in and they're having difficulty breathing, they have bronchospasm, and it asks you, what's the first thing you need to do? Yeah, and then what next, potentially? Okay, yeah, maybe a steroid, maybe even a long-acting bronchodilator too. And a lot of the dry powder inhalers, like the Advair and that, is actually a mixture of a steroid and a long-acting bronchodilator. But again, those still maintenance therapy, right? And then we talk about preventative therapy. We can look at our leukotriene inhibitors or mast cell stabilizers. So that was the brunt of what we talked about, and hopefully that is a little helpful for you guys. Okay. We covered the major doses, and I'm not really going to get into any more detail than that. In some of your other classes, they may ask some other questions, so I'd still read through the chapter. But these are the major things, and these are the big things that they're going to hit you with in clinicals, these the major meds you guys will be given. So does that kind of help clear any things up from last week?